Hello and welcome to the program. I'm your host, Neal Howard. Thank you so much for joining us again. Our guest is Dr. JoAnn Pinkerton. She's Executive Director of the North American Menopause Society, or NAMS, and she's joining us to discuss the benefit of hormone therapy. Too many women are suffering because they're unnecessarily afraid of hormones. And our guest is going to talk about the reason that could be, according to a Women's Health Initiative study back in 2002. But I'll let our guest get into that. Welcome to Health Professional Radio, Dr. JoAnn Pinkerton. How are you?
I am fine. Thank you very much. And I'm so excited to talk about something I'm passionate about, which is helping women through menopause.
Now, menopause, most of our listeners are healthcare professionals, and we're all familiar with the term menopause. But for anyone who may not be as up on the term, what exactly is menopause?
So menopause is defined as a year after your last period. What's more difficult is the perimenopausal time when your hormones are fluctuating, going up and down. And then postmenopause is a year after your period when you are definitely menopausal. And the biggest problem is that 75% of women have hot flushes, 25% of them severe enough that they seek therapy.
Those are just one of the symptoms associated with menopause, loss of libido. Sometimes sleep can be affected as well, yeah?
Absolutely. The mood changes, sleep disruption, hot flushes, night sweats are common. Some women will have joint aches or may have other symptoms along with it. And then, of course, we worry about bone loss down the road from women who have less estrogen.
Now, I mentioned that there are a lot of women who are suffering unnecessarily due to fear of hormones. Now, this fear it's not a healthy fear, is it? Could you talk about why some women are afraid to undergo or to begin hormone therapy?
In 2002, when the first release of the Women's Health Initiative's large randomized trial was released, there were risks of breast cancer, heart disease, dementia, stroke, and blood clots, and women stopped their hormones. And since that time, and it's now been 15 years, there still continues to be a lot of confusion and fear for women and their healthcare providers. What we did in the past 18 months was look at all the data, including all the studies that have come out from the Women's Health Initiative, as well as longer observational trials, to look and say, who is it safe to take? Who's safe to take hormones, and how long can they take it? And we published this 2017 position statement to try and help providers know who it's safe for.
And what were your findings as far as who's the best candidate and safe candidates for this type of therapy?
So it is very clear that menopausal women who have either hot flushes and night sweats or are at high risk for bone loss, who are younger than 60 or within 10 years of menopause, are the group of women where the benefits are going to exceed the risks. So it's for treatment of hot flushes, sleep, and prevention of bone loss. For women who are more than 10 years from menopause, or more than 60 or 70 years of age, then the risks actually seem to go up, and then we wouldn't recommend starting hormones at that time.
Is there anything suggested that they do instead of hormone therapy, maybe an altered diet or...
Well, I think that there are options for women who are older, and I'll get to that in just a second, but I wanted to say, after the WHI, the concept of the lowest dose for the shortest period of time became sort of the mantra, and no one would use it longer than 3 to 5 years because there was this increased risk of breast cancer. But when they really looked at the data, it turned out that estrogen by itself, conjugated estrogens, had a decreased risk of breast cancer, and the increased risk of breast cancer was actually very rare. So fewer than 8 out of 10,000 women developed breast cancer, and it was on a much higher dose than we use with a much stronger progesterone. So even if we just kind of stay within that safe group, we can look at when you're starting it, that we have new lower dose products. We have products that are through the skin or transdermal, so they avoid the liver. So there's less risk of strokes and blood clots. So we have a lot of new options for therapy that were not available in the Women's Health Initiative when they only looked at one product. For women who have problems who are older, then you got to think about, is it a hot flush problem or a bone loss problem? Hot flushes, we can use low-dose antidepressants or gabapentin. and there's a lot of medications out for prevention and treatment of bone loss for women.
What about women who've undergone hysterectomy? Is that related in any way to the effectiveness or the safety of this therapy, whether or not the age is a factor?
So you bring up a really key point, Neal, which is that women who have an early menopause, so average age of menopause is 52. Let's say you had your hysterectomy and ovaries out at 42. You have an increased health risk of dementia, bone loss, heart disease, vaginal problems, mood issues, Parkinson's. And it turns out that that group in particular are really good candidates to take hormone therapy because they can use estrogen by itself if their uterus is gone, or a standard dose of hormone therapy at least until the age of menopause, and that seems to take those extra risks away. And for women who don't have a uterus, you don't need to take progesterone, and it seems that the synthetic progestins increase the risk. So estrogen by itself appears to either be safer or have no increased risk of breast cancer, or maybe slightly decrease the risk, as well as, still relieving hot flushes and preventing bone loss.
What about intimacy issues as women approach or are going through dealing with menopause? Are some of these therapies beneficial in that area, or should she just expect, loss of libido, vaginal dryness, and things of that nature to be the norm?
So I would say strongly, women don't have to lose their ability to be intimate. They don't, loss of libido may be common. There's some options for that. And many women have painful sex and they're afraid to talk about it. And many providers are afraid to ask. But if the problem is just what we call vaginal atrophy, or there's an even bigger term now called genitourinary syndrome of menopause, because it also involves the bladder, local estrogen products work very effectively and they're very safe. And these are estrogen creams or a low-dose vaginal estrogen tablet or a low-dose vaginal estrogen ring. And there was just a paper published last week in Menopause from the Women's Health Initiative that showed that women using these vaginal therapies did not have an increased risk of breast cancer or uterine cancer or heart disease or stroke. There's a boxed warning, but it doesn't apply. So those are safe options. And then there's a brand new medication that has just been approved by the FDA, which is an intravaginal DHEA. And it's really like a pro-hormone, so it increases estrogen and testosterone in the vagina, helps with painful sex, helps with intimacy, and may also help with some of the libido and arousal issues. They're doing ongoing studies about that. So there are options for women. And of course, you remember that flebanserin being sold as Addy has actually been shown and is approved to treat premenopausal loss of libido, although it may also work for postmenopausal women.
And what about some good online resources where women can find a menopause specialist in their area?
So our organization, the North American Menopause Society, has an online webpage, menopause.org. There is a section for women, so we have information about everything from hot flushes to bone loss to what you can do with and without therapy. We have an area on sexuality. And then there's also a little section that says to find a provider in your area. And all women need to do is put in their zip code, and it will show you 3, 4, sometimes 10 providers in your area. And if you check the little box that says NCNP, it means that they have been certified. They've taken a test and shown that they're a menopause specialist. And everyone who has taken the test or is a member of NAMS really care about women going through menopause and afterwards, trying to help people navigate and make the best choices for them. This whole concept of individualization based on the woman's, her own health risks. What do we know about the types of therapy, what we're trying to treat? And you don't even have a set stop date. You don't have to say it's 3 years you have to stop or 5 years you have to stop. 5 years, still having symptoms. Think about dropping the dose. She's 60, still having symptoms, seems to be doing well. You can lower the dose. You can go to a transdermal product. You just have to kind of weigh the own woman's risks and benefits with what we have, spent a lot of time looking at the evidence so that we can say these lower doses, transdermal doses, are safer for women, particularly as they age. There may be risks also.
The cancer risk?
So it looks like estrogen by itself does not increase the risk for breast cancer, but estrogen and synthetic progestins, the ones that we used 10, 15 years ago, do. We now have a natural micronized progesterone that in a big French study didn't show an increased risk, so we can combine estrogen and a progesterone together for women with a uterus. And there's a product that's been on the market about 3 years now that is an estrogen combined with a designer anti-estrogen, and that doesn't need a progesterone at all. And it's really exciting because there's no breast tenderness or bleeding. It's very similar to taking placebo, but it helps hot flushes and prevents bone loss. It's sold by the name of Duave and has a long name, tissue selective estrogen receptor complex. But it's really exciting because we have more options for women than we've ever had if we could just get past the fear and make both women and providers be less nervous about talking about hormones.
Well, thank you so much for coming in, Dr. JoAnn Pinkerton, Executive Director of the North American Menopause Society. It's been a pleasure, and I'm hoping you'll return.
Thank you very much, and I'd be happy to.
You've been listening to Health Professional Radio. I'm your host, Neal Howard. Transcripts and audio of the program are available at healthprofessionalradio.com.au and also at hpr.fm. You can subscribe to this podcast on iTunes, listen in, and download at SoundCloud. And be sure and visit our affiliates page at hpr.fm and healthprofessionalradio.com.au.